Hello everybody, I'm Ahmed Sarwar. I'm a third year medical student in the University of Suleimania of Kurdistan, which you probably has never heard of. So let's try and change that. So basically in this short video, we're going to be talking about hyperthyroidism. What is hyperthyroidism as basically lab results, signs and symptoms, and some of the most common medications that are used in the treatment of hyperthyroidism. So let's start. Basically, hyperthyroidism. Hyper means increase. Thyroidism means related to thyroid gland. So hyperthyroidism is a condition that we have an increase in the level of the thyroid hormones, basically T3 and T4. And the most common cause of hyperthyroidism is Graves' disease, which is an autoimmune condition that's characterized by the production of antibodies in which they are basically stimulating TSH receptor on the surface of thyroid gland, leading to an increase in the growth of the thyroid gland and an increase in the production of T3 and T4 even in the absence of TSH. So it is basically type 2 hypersensitivity reaction if you are interested in immunology. So we can also have other causes of hyperthyroidism, for example, thyroiditis, which is inflammation of the thyroid gland, or multinodular hyperthyroidism, in which we have multiple nodules in here around the thyroid gland, which can fill every single one of them. So let's start with lab results of the hyperthyroidism in general. So basically, in lab result of hyperthyroidism, you have increase in the level of T3 and increase in the level of T4, but a decrease in the TSH. The T3 and T4 is increased basically based on the name, it's obvious, and TSH is decreased as a compensatory mechanism, as a defense mechanism by the body, that the body is trying to fight back in order, basically the body is saying, okay, we have increase in T3 and T4, let's decrease TSH, so the physiological T3 and T4 will be decreased, and hopefully the concentration of T3 and T4 in the blood will be corrected, which will not happen, obviously. That's why we need medication. So that's about lab results. Now let's talk about signs and symptoms. For signs and symptoms, you need to understand the basic function of T3 and T4, in which we know basically T3 and T4 are responsible, for example, in the heart for increasing heart rate. So hyperthyroidism will lead to tachycardia, an increase in the contractility of that. Basically, in the metabolism area, T3 and T4 are associated with an increase in the level of BMR. So hyperthyroidism will lead to massive increase in the BMR. Massive increase in the BMR means the person gonna get weight loss. The person gonna have good appetite with weight loss. Keep it in mind, because weight loss, as we all know, can also occur in cancer, for example, or stuff like that. In cancer, the weight loss is associated with pure appetite. The person has no desire to eat. The person has loss of appetite with weight loss. But in hyperthyroidism, we have good appetite, but the person is still losing weight due to increased BMR. The person can even be eating so many food, but due to the increased BMR, the person gonna be losing weight. Another thing is temperature to consider. Basically, T3 and T4 are controlling heat production. So increasing T3 and T4 will lead to massive heat production, the formation of heat intolerance. The person cannot tolerate basically warm weathers, and also massive sweating. So person gonna have heat intolerance with sweaty skin. Another thing to keep in mind basically is mood of the patient. T3 and T4 are maintaining mood, but the massive increase in the level of T3 and T4 gonna cause anxiety, gonna cause, for example, always being angry, always having a temper, and being moody and stuff like that in general. So that's about signs and symptoms. Now let's come to treatment. So basically, we know in hyperthyroidism by now that we have increased in the level of T3 and increased in the level of T4. So we want to decrease this. So what we can do, we can give anti-thyroid medication. What we can do, we can give radioactive iodine, which is going to be basically destroying or basically destructing the thyroid tissue. We can be taking the thyroid gland either partially or completely out, thyroidectomy, or maybe we are doing symptomatic management using beta blockers such as propranolol or ismolol. So let's start with anti-thyroid medication: methimazole, carbimazole, propylthiouracil, or PT. These three drugs are basically, all of them inhibit thyroperoxidase. These two are doing it directly, and carbimazole is a product that inside the body is going to be converted to methimazole. So giving carbimazole is just like basically giving methimazole. But that's a product which can have detailed differences, which we're not going to get into. But just now, this one is a product and it is converted into methimazole. So basically, they are inhibiting thyroid peroxidase, meaning that they are inhibiting the production of T3 and T4. But propylthiouracil is also inhibiting the conversion of T4 into T3. So when are we using propylthiouracil? When are we using methimazole? Basically, the idea is propylthiouracil, since in addition to decreasing the production of T3 and T4, prevents the conversion of T4 into T3, in which T3 is the active form of the thyroid hormone. Propylthiouracil can be used in thyroid storm, in which you have a massive amount of thyroid hormone, because you want to decrease the amount of T3 as fast as we can. So that's why propylthiouracil can be used in this area. Another thing about their usage is basically understanding their side effects. The most common side effect of propylthiouracil is liver damage, leading to hepatotoxicity, hepatic failure. It can also cause granulocytosis to a lesser degree, but mainly it is causing liver damage. Therefore, in liver problem patients, we are not using PTU. Instead, we are using methimazole, in which the most common side effect of methimazole is agranulocytosis. Agranulocytosis means decreased white blood cell, by the way. It may also lead to rash. It may also cause hepatotoxicity, I'm not going to lie, but the hepatotoxicity in here is much to a lesser extent in compared to propylthiouracil. Therefore, this one can be used in liver damage, but this one cannot be used in liver damage. But methimazole is causing birth defect in the first trimester of pregnancy. Therefore, in the first trimester of pregnancy, we are using propylthiouracil. In the second and third trimester of pregnancy, we still usually are using propylthiouracil based on consideration. We can scientifically use methimazole, but propylthiouracil is used unless we have to change it to methimazole. For example, maybe we have liver problem or something like that. But there is no risk of also using methimazole, to be honest, because methimazole is causing defect in the first trimester. It's completely safe in the second and third trimester. So that's about antithyroid medication. Now let's come to radioactive iodine, or I-131. Basically, we know for the production of thyroid hormone, we need iodine, in which we're going to be absorbing it from the diet and transporting and then uptaking and all that, yada, yada, yada. Basically, I-131 is just using this mechanism. We're going to be injecting I-131 into the body, radioactive iodine, and then the thyroid gland going to be uptaking it. This is going to be emitting radiation and leading to the destruction of the thyroid gland. That's all. The most common side effect and the most common risk with this is overcorrection leading to hypothyroidism. Of course, if you just forget about the radiation, which we shouldn't. Obviously, there's also risk of radiation. It is completely teratogenic, should never be used in pregnancy, and all that. Now let's come to thyroidectomy. Thyroidectomy is the last resort because you are basically doing surgery, and surgery always have complications. Basically, you are either taking part of the thyroid gland out or the entire thyroid gland. The most common complication, obviously, is hypothyroidism. Maybe posterior to the thyroid gland, we now closely related to it, we have parathyroid gland, so maybe it is leading to hypoparathyroidism as well. And closely associated with the thyroid gland, we also have the laryngeal nerve, so maybe it is leading to the damage to the laryngeal nerve. So all of those are complications of thyroidectomy. That's why it is a last resort. So what about symptomatic management? Propranolol and esmolol. Basically, these two are beta blocker, and one of the common side effects of or common sign and symptoms of hyperthyroidism, is basically tachycardia, tremor, and stuff like that, anxiety. Propranolol and esmolol can be are beta blockers, therefore they are leading to decreased heart rate, leading to decreased tremor, they are leading to basically decreased anxiety. They are used for symptomatic management. They are not treating hyperthyroidism. They have nothing to do with hyperthyroidism in general. But keep it in mind, propranolol technically is inhibiting the conversion of T4 into T3. So what are inhibiting the conversion of T4 into T3? We have propranolol and PTU. Both of them are starting with P, so they are inhibiting the conversion of T4 and T3. That's how I personally am remembering it. But besides that, they are just for symptomatic management, and their side effect is just the side effects of beta blockers. Maybe they are leading to bronchoconstriction, maybe they are leading to severe bradycardia, hypertension, or even heart failure and stuff like that. So that's about it, about hyperthyroidism, from lab result to science and system and everything else. Thank you very much for watching. Please tell us in the comment section any comments or basically opinions, suggestions that you have about ways of teaching. What shall we change? What shall we keep? And tell us what do you want us to talk about in the future videos. And have a great time, everybody. Keep studying, and goodbye.